Thank you so much for joining us, and welcome to the Center for Ethics and Human Values Conversations Around Research Ethics panel. The Center for Ethics and Human Values CARE program is funded by the Office of Research with support from the OSUMC Center for Bioethics, which is where I'm housed. I'm Dana Howard. I'm going to be moderating, and also the College of Public Health. Today, we will be speaking about a topic that is so central to ethical research. It's actually kind of surprising that we haven't yet touched it. I mean, we've obviously touched it in a lot of different conversations, but I'm so excited about this timely conversation today. We have a really exciting panel. Joining us from University of UMass Amherst, University of Massachusetts Amherst. Danielle Bromwich is a philosopher who's a leading expert on the ethics of consent and has published widely on the moral power and conditions of valid consent, particularly in the research context. And Dr. Bromwich is in the process of writing a book on consent with her co-author, Joe Millam. We also have a really exciting panelists from Ohio State, our very own Dr. José Javier Otero, who is Director of Neuropathology at OSU College of Medicine. Dr. Otero has been thinking about some of these issues for a few years, and we've had conversations about the challenges that he has faced as a clinician researcher, ensuring that his patients understand and freely volunteer to have their data used for research purposes. And I'm really excited to talk to José Strickler, who is a PhD student at the Nisonger Center, which is the University Centers for Excellence in Developmental Disabilities. And José's thesis project was focused on adapting the informed consent process to make it accessible to adults with intellectual disability. So I think that we have a really exciting panel to tackle this issue from a number of perspectives. So for those of you who are new to these panels, it's very conversational in style. We'll start with Dr. Bromwich, who will give sort of an overarching sort of framing of the way in which you've been thinking about these issues in your work and research. Then I'll give our OSU panelists 5 minutes to just sort of respond with your own experiences, challenges, and how you've been thinking about informed consent. And then I have some questions that I came up with that I think will spark conversation, but really these conversations are for you, dear audience, to just like really talk about these issues and bring up issues that you have. So as you're listening, there is the Q&A function at the bottom of your screen. Feel free to type away any questions that you may have, and we'll try and get to those for a large portion of the end of this very short session. All right, so to no further ado, thank you so much, Dr. Bromwich, for joining us, and I'll give you the floor.
Well, first of all, thanks so much for organizing this panel. I'm really excited to be here with you and José and José today and all of the people who are attending. So I became interested in informed consent about 15 years ago now, when I was a postdoctoral fellow in the Department of Bioethics at the Clinical Center at the National Institutes of Health. And there I was introduced to this large body of empirical evidence that showed us just how much or how little patients and healthy volunteers really understand about the trials in which they're enrolled. And these are people who are asked to give informed consent to research participation. They're told an awful lot about the research that they'll be part of. And what we see is that there are large numbers of even well-educated, mentally competent people who just routinely can't identify key facts about the trials in which they're enrolled. So to give you a concrete example, in the early 2000s, Steve Joffe and his colleagues conducted a research study with American cancer patients that were enrolled in trials at the US Cancer Institute. And they found that 29% mistakenly agreed to this statement, which I've written down, which is the treatment being researched in my clinical trial has been proven to be the best treatment for my type of cancer. A further 40% were unsure whether that statement was true. 64% were unable to identify that their trial had additional risks when compared to standard cancer treatment. So, like many other people at the time, I found myself kind of troubled by these studies on poor participant comprehension. And like many other people, I started to wonder whether people who understood so little had actually given informed consent to research participation. Now, the standard view of informed consent, the view that we find enshrined in research ethics regulation, the view that is disseminated in all of the major guidance documents, the view that's held by many bioethicists and people who conduct human subjects research, tells us pretty clearly that these participants did not understand enough to give valid consent, because that view of informed consent tells us the reason we disclose all of this information to prospective research participants is because they have to understand it in order for consent to be valid. But if I'm going to be really honest, what got me really interested in informed consent was my fellow research ethicists' reaction to these studies on poor participant comprehension, because these were scholars and practitioners who pretty much agreed that much of this research required valid consent. They held a view that told them that people had not given valid consent given their poor understanding, but they only seemed mildly concerned about the poor understanding. And I found this utterly baffling, because I thought, if you really think that consent is invalid on this scale, you'd expect outrage. And so I was struck by this mismatch in theoretical commitment and practical attitudes. The theory demanded outrage, but their practical attitudes were far more muted than that. And I think that those reactions are really perfectly encapsulated by this lovely study that Laura Beskow and Kevin Weinfurt conducted a couple of years ago now, that was published in the American Journal of Bioethics. And they convened this multidisciplinary expert panel, research ethicists, who achieved agreement on a set of facts that they said needed to be understood for participants to enroll in this biobanking research. And then the panel was presented with evidence that a third of the participants had not understood several of the key facts. And they wavered. So on multiple items, over 30% of the panel. Oh, can you hear me?
I can hear you. I can hear you.
You can hear me, Jesse? Okay, I heard Lily come in. So over 30% of the panel were willing to enroll participants who'd not understood key data into this trial. And when they were asked about how they could do that, when they held a view that said these people have not understood enough to give valid consent, they really struggled to reconcile their intuitions. So they, on the one hand, held a view of consent that said, look, these people have not given valid consent. We need to exclude them. But on the other hand, they sort of intuitively felt like if these participants are willing, we should let them be in the research. So I'm going to put my cards on the table here and tell you that I've always thought there was something in this muted reaction. So my friend and co-author, Jo Millam, and I, we found ourselves really resistant to the idea that you have to, or that consent is invalidated when you don't understand everything that ought to be disclosed to you. So we've now published a range of papers that we think shows that this sort of central claim of the standard view of informed consent is mistaken. We think that the achievement of understanding is an aspiration of disclosure, but it's not a requirement. And I think at this point, it's really natural to ask, why on earth not? So I want to give you a quick argument about that, and then I'm going to introduce you to sort of this alternative view. So take something that most people think needs to be disclosed and understood in order for consent to be valid. Take risks. Now consider, I'm a philosopher, so you have to bear with me as I give you a thought experiment. But so now consider two cases of an informed consent process. So in the first case of this informed consent process, let's say for an experimental drug, the researcher knows the drug has risks A and B. She doesn't know about risks C and D, and she's not negligently ignorant because no one knows about these risks at this point in time. During the informed consent process, she discloses that the drug has risks A and B, and she says, look, there may be further unknown risks. Participant fully understands this information, agrees to ingest the drug. If we assume that everything else about the informed consent process is impeccable, this is a classic case of valid consent. Now imagine a second case, which has just got one variation. In this case, the researcher knows the drug has risks A, B, and C, but once again, she doesn't know about D, and once again, no one else knows about D at this point. During the informed consent process, she does what she did before, she discloses that the drug has risks A and B. There may be further unknown risks, but she withholds risk C. Once again, the participant understands the same information. The drug has risks A and B. And even if everything else is impeccable, this looks like a case where we think consent is invalid. So what explains the difference between these cases? Why I think consent is valid in the first but not in the second? One thing to notice is it can't be understanding because the participant understands exactly the same information in both cases. The participant understands the drug has risks A and B. That was sufficient for valid consent in the first case. So it's not sufficient in the second, we need an explanation. Well, you might think, well, here's the explanation. You need to understand all of the actual risks of the drug to give valid consent. But that can't be right either, because risk D is never disclosed because it's not known by anyone. And in fact, it's routine in clinical research that we are asking people to give consent when they're always going to be ignorant of some fact about the research, because the reason we're doing the study in the first place is to find out things that may end up being relevant. So we think that it is possible to give valid consent ignorant of risks. And even though risks ought to be disclosed if known, valid consent doesn't always require that they be understood. Now that's controversial and we'll probably come back to that. But if the standard view of consent is mistaken, how should we think about informed consent? And so what I want to do is give you a quick kind of tour of this alternative view that my co-author and I have developed. We think it does a better job of explaining why consent is valid in that first case, but not the second. And we also think it can explain why some of that muted reaction to the data on poor participant comprehension might well be justified. So let's start with disclosure. If the achievement of understanding is not the purpose of disclosure, what is the purpose of disclosure? Why should we disclose certain facts, and what facts do we need to disclose? Well, we think that the purpose of disclosure is to avoid a kind of control that can invalidate consent. So if you control somebody else's consent decision, you undermine the voluntariness of that consent decision, and that can result in invalid consent. Now, we typically think about this with cases of coercion, like threatening to make someone worse off. But you can also control someone's decision by controlling their access to information that's relevant to that decision. And we think that's what's going on in that second case. That researcher knows a risk C. She has every reason to believe it's relevant to the prospective participant's enrollment decision. She has every reason to believe that that participant would expect to be told it, and yet she withholds it. That kind of control is illegitimate, and that kind of control can invalidate consent. And this is useful because it helps explain that researchers have substantial duties of disclosure. They ought to disclose what they know, what they have reason to believe is relevant, and what they would expect a participant would expect to be told as part of a consent process. Now, it's also really important that that information is disclosed in an understandable way, right? You don't give someone access to information if you disclose it in a way that they cannot comprehend. So these duties of disclosure are not just about disclosing certain facts, but paying attention, as José has been doing, to how people process information and making that accessible to them. Now, that view of disclosure tells us what we ought to disclose and how we ought to disclose, but nothing in that explanation implies that you need to understand everything that ought to be disclosed. So what do you have to understand? Well, we think if you're going to preserve the practice of actually giving and receiving consent, you can't expect people to understand everything, otherwise consent would be impossible. You can't make consent completely ignorant, otherwise we can't distinguish you consenting to this rather than that. So we think that what you need to understand is A, that you're giving consent, B, how to give consent, and C, what you're giving the researcher permission to do. But notice that you can understand what you're giving the researcher permission to do, say a blood draw, without understanding why the researcher is doing that, what the purpose of the research is, or even the associated risks. So that's sort of the view in a nutshell. And I want to just finish off by giving you one nice implication and then two words of caution. So nice implication, if we're right, and who knows, but if we're right, then I think we've shown that that muted reaction to the data on poor participant comprehension might well be justified, because if you go back to those studies that show, oh, people don't understand randomization or risk or purpose, Well, provided that they did understand that they were asked for consent, how to give their consent, and what they were permitting the research team to do, they may well have understood sufficient to waive their rights. And provided that the research team disclosed in a clear manner considerations that would be relevant to their decision about whether they wanted to be in the research, duties of disclosure might have been met too. And so we could be reassured, if we're correct, that actually the number of participants who gave invalid consent might well be quite small. We also can explain why some of those research ethicists surveyed in Beskow and Weinfurt's study may well be right that willing participants who maybe don't understand this item or that item should still be permitted to be in the research if they want. So 2 words of caution. So first of all, nothing I've said so far implies or should be taken to imply that everything is like golden and rosy in the informed consent process. Absolutely not, far from it. And I think one area that is an area of concern for me, and I'm excited to hear about Jesse's research, is that I think we should be very worried about features of the disclosure process. We know that consent forms are far too long, they're written at way too high a reading level, they contain scientific jargon, they contain institutional protections, they don't facilitate understanding. And I think that we need to pay a lot of attention to how we communicate with ordinary human beings and how they process information to give them a fair opportunity to make decisions that align with their interests. The second thing to say is that our analysis focuses on one function of the informed consent process. We think it's the main function, but it is one function, and that is the requirement to obtain valid consent, the requirement to waive your rights. But many other people have argued, and they're right about this, that informed consent serves multiple functions, right? It can promote good decision-making, it can build trust, it's about integrity in scientific research, it's about transparency. And so there are ways in which these functions can come into tension, especially for someone like me, because I might think, or I do think, that you might be able to waive your rights and give valid consent, not understanding certain risks. But I'd also accept that not understanding certain risks might mean that you can't make a good decision. And so I think that researchers can get caught in that difficult situation of not always knowing what to do when they think, well, this person is willing and they seem to understand enough to know what we're proposing, but I'm really worried they're not making a good decision. So we can talk a little bit more about that tension, but that's sort of my view in a kind of whirlwind tour.
Thank you so much for those provocative, but also I think like really interesting and like piercing remarks. So maybe we'll start with Jesse, since Danielle, you brought up some of the worries that you have. So Jesse, if you can bring up some, your own research and how you've been sort of the challenges that you have faced in your research, and then we'll go to Jose after that.
Sure. Well, thank you for that introduction and that really, as was just said, really provocative questions and interesting topics for sure. I agree with what you were saying. My introduction and interest to this subfield, came when before graduate school. I was working in clinical trials in geriatric psychiatry, the kinds of big, large-scale, high-risk biomedical studies that you're talking about, incredibly long consent forms, varied risk, placebo arms, randomization, et cetera. And in geriatric psychiatry, in a population with advanced Alzheimer's or other dementias, where there's a baseline understanding that there's going to be complications with understanding and providing consent. And just as a research coordinator on those projects, navigating a complex and frankly convoluted assent and consent process, I was just operating in an existing bureaucracy and existing trial. So then I came into graduate school here at OSU. My field of interest is psychology, specifically in intellectual and developmental disabilities psychology. And here's another population where there's an assumption or a baseline understanding of cognitive limitations, differences in learning, differences in comprehension, and in research in this population, issues of consent and assent, individuals who are not their own legal guardian, and so on. So I brought that interest in, and something that comes up across the board, that researchers want to do better. Ethical researchers who care about ethics and care about their research participants want to do a better job of the informed consent process. And I deliberately emphasize the word process because I think that's, it's overlooked. It's not a moment in time. It's not a sheet of paper. It's not a yes or no question. It's a process, and it's ongoing, and it's fluid, and it should continue to be flexible. And I think that it's aspirational, but I think that's the best we can do, is be flexible. And that can mean many things. Flexible to the situation, to the capabilities of the individual. And one thing that has come up consistently in reading of the literature and thinking about this is that this bar, whether we're willing to set a firm bar or not, of enough comprehension that this is now ethical, valid consent. And I would argue against doing that, actually, but that needs to be proportionate to something. Not all studies are the same, right? A clinical trial with an experimental drug with known or unknown risks, you can't expect that to be the same as a 30-minute survey where the only risk is this abstract concept of your confidentiality being breached that we don't at all expect to occur, which is the vast majority of research in the social sciences, the kind of risks we're looking at. So briefly, what our project was, I agree with everything you said, Dr. Bromwich, and I find that, we have this aspiration of people making informed choices, and the tool we have to do that is these informed consent forms that are vetted and approved by the institutional review boards and et cetera, that are full of legalistic jargon. They're too long. Frankly, the typeface is too small. The layout doesn't make sense. It's just not conducive to learning. It's not the right tool for the task. And my advisor, Dr. Haverkamp here at OSU, and I, we sought to, we know this is not the right tool for our participants. So how can we modify it? So we compared sort of a status quo presentation, something that the IRB would approve today, their template, to two modifications. One, an easy read document, of which there are specific guidelines to produce those, right? Lower reading level, larger typeface, avoiding particular kinds of words. The graphical presentation matters. And we also did a purely verbal conversational form where you don't have your attention divided between a form and someone who's reading that form out loud. This is a conversation, and I'm going to make sure that you understand each point before we move on to the next. And we compared those three conditions and then assessed with open-ended questions comprehension of what we determined in this particular study to be the 9 highest priority facets to demonstrate their comprehension. And although we did not find one mode superior to another as far as the conversational or the easy read, what we did find, they were presented in succession. So everyone actually was given the status quo form first, and that established a baseline. This is what you understand if you're given the information how we're supposedly supposed to. And then can we improve upon that? And that I think I can say with confidence that if you put in the effort, if you make the accommodations, you can see really profound improvements. And as we had a kind of qualitative aspect of assessing feasibility, likability, and preference, and the participants really appreciated being met at their level and that accommodations were being made. So I think those are the most important conclusions to share from that project.
Thanks so much. And Jose, do you want to go next?
Sure. Thank you for inviting me and participating in this really interesting discussion. I have to be honest, I didn't know I was interested in informed consent until Dana told me that I was asking informed consent questions. I'm a physician scientist, and I'm a director of a diagnostic service line where we diagnose brain biopsies. And I'm not very much involved with the types of prospective interventional type trials that my colleagues have discussed where consents occur. I think I landed on this panel for a couple of reasons. One is that there's a certain type of research that's going on with, and I'm going to say unconsented research. I'm not implying it's illegal research, but it's a research that is necessary to improve patients' lives now and in the future. And it has a lot to do with data analysis. And this is where my experience in this kind of process and some of my ethical dilemmas have arisen. The types of issues that I face in this context are, let's start from the premise that I do believe, it's an opinion, but I do believe that machine learning and artificial intelligence are as impactful to medicine as antibiotics have been. And within 5 to 10 years, these models will be super important in scaling up healthcare. I mean, we have 380 million inhabitants in the United States. That's going to increase, and we need that kind of scalability. So I start off from that ground truth of this is a necessary tool for modern medicine moving forward. And much of the issues of things that we need for that, for our, let's call it personalized medicine and so forth, require workflows that benefit from economies of scale so that the cost per patient goes down. So that's a reality. So that's resulted in centralization of data and machine learning and AI model development being generated through these centralized, at times, nonprofit tertiary care centers, at times, for-profit companies. And the aspects of who owns that, participating in the healthcare system means that you're contributing to the model generation. Do you even know that? And how do you feel about your testing being used to create a necessary model, but nevertheless, it's being used in any case. In terms of the research that I've been involved in, I would say I participate in a fair spectrum of unconsented research that's in the context of quality control. So this is research that's necessary for normal operations in a hospital, but for which consent is so bureaucratic, and it's not for like research publication or something like that. As a clinical director of a service line, I routinely go back and see how our diagnoses are, what are our concordances. So that's research, but it's more like quality control, not really for publication. And it's for improving our hospital. That's necessary. And then as a researcher, dealing with the frustrations of the consent process from my side of being the fact that I'm not an attorney. I feel like I need to be an attorney. I'm not a philosopher. And in general, the support in the education of the investigators on how to go about that is so lacking. Not just at Ohio, I think all over the United States, maybe even the world, that you end up with these applications that take months to fill out. It's very bureaucratic, it's very frustrating. And then in the end, it's so wrapped up in legalese language that no one understands what's going on. So that's my experience with it. So I'm not a person that's been involved in the development of trials that are for prospective interventions. But my concerns are mainly about the research that's going on right now. How do we make that, if everyone is participating in it, will everybody benefit? And where will that benefit go, and how will it be distributed?
Thank you so much. And So, I mean, one thing that is just sort of like to point out about Jose's like sort of questions is, so if it's quality improvement, then it's officially not understood as research as long as it's not going to be published. So there's already like built into the regulations, there are these somewhat artificial, non-folksy understandings of what counts as research and what doesn't. And in some ways they're related to what seems to require informed consent to actually engage in that kind of inquiry, I will say, versus not, which I think is super interesting. So maybe Danielle, do you want to just sort of quickly respond to any of the points that were made by Jesse and Jose, and then I'll open it up to questions.
So this be a bit random. There was lots of really interesting stuff. So with Jesse, I was thinking that I was thinking about the fact that I don't know if you've noticed this, but I think that there's something about the way that the forms we have are set up that don't even invite the right kind of engagement, right? I mean, they look really similar to terms and conditions. And so are you going to react to them in that way? Whereas the other things you were talking about, you know, where you've got the font that's large, or you have the conversation, already it's already set up in a context where it's clear to you that this is part of the process where you get to be a decision maker. The other thing I was thinking as you were talking about this is that you said that a lot of the participants really appreciated these sort of other ways of engaging in the consent process. It really relates back to that sort of principle of respect for persons, like actually respecting the research participants. The way that researchers are forced to put these consent forms together by IRBs and research ethics committees and to meet all of these requirements doesn't really show an awful lot of respect for the research participant, because it doesn't facilitate understanding, and it's not really a way of engaging them in the process. So your work sounds absolutely fascinating, and I do think that you're focused on, as you said, populations where we already have concerns about the ability to understand. And I just think it's even wider than that. Everyone's struggle. I mean, and to really put my cards on the table, one of the papers I wrote a couple of years ago was about HIV cure research. And so I looked at a bunch of consent forms. I have a PhD, admittedly, in philosophy, but I just couldn't understand a lot of it. And I think I read at a fairly high level. So if you have a PhD in philosophy and you're saying, I don't really understand what the purpose of this research is, then that's clearly written at too high a level. So that was my thought, is that a lot of this, I think, connects nicely to respect, and also just connects to these other ways in which we communicate that we're interested in decision making. And then, Jose, wow, this is so fascinating, and I can see all of the ethical questions that are coming up for you. One question I have, which I guess is a question, is the data that gets collected, is it easy to anonymize it completely, or are there worries sort of later on that there might be ways of identifying certain people?
Hi, yeah, so regarding the question of anonymization, a couple of things to consider, including, and kind of also I wanted to preface it by, why did I include this concept of quality control in this discussion, is that the infrastructure of generating data capture at the user level, when I'm talking about nurse practitioner, physician, requires a significant amount of informatics insight so that it can be retrievable, okay? And that's required for both the quality control stuff, which is absolutely necessary for hospital function, period. Like, you can't function a hospital without being able to go back and say, are we missing pneumonia? Something like that, that's normal. But it's also important for the retrospective research, which is the basis of the machine learning AI algorithm. So those things can be anonymized in the sense that at some point they can be converted, but you still need to at one point here, number one, determine, well, who is the owner of the model? right? And so so even though you might be able to anonymize the data and control for certain things, so that people's identity or maybe embarrassing features of them, or who knows, maybe there might be certain things about their clinical history that they've disclosed that are illegal activities that could then put them in crime. We have things like all these things that come up, right? So those processes of anonymization are present and they are practiced. But the ethical issue here is kind of like, well, if my daily blood pressure measurements have been used, right, for this model generation, and that model generates an IP that is then commercializable, and now the Kaiser system is arguing they've got a better ML/AI prediction tool for whatever disease compared to this other person. Now they're using it for marketing to get more like footprint in the marketplace, right? So a lot of these, that's kind of the angle that I'm coming in. So the anonymization, I think I don't know if it works perfectly, but it does work in terms of the research. So for example, I think it would be very hard for somebody to read a research article I've done in biomedical research and then find out the person and their credit card number. I think that would be, I'm sure it's possible that with some like hacker or something breaking into the firewall, but it would be very difficult and unusual, for that to happen with the protections in place, let's say, but I think that the point of the consent process that I'm concerned about here is how do we, if we're using the patient's data for what's becoming the most important thing, and what is that public policy framework that we want to put that in, right? If now you have these private companies that have the algorithms. So right now, I'll give you a specific example. There's a company called Caris Life Sciences which is a molecular testing company that now has an algorithm that can predict with high accuracy if you have a metastasis from what primary organ this came from. It's an extremely useful tool, but that's owned by Caris. So in order to use that model, which is built off of 200,000 patients, right? I got to do business with Caris. I got to send my stuff to Paris. Caris has so just by practicing medicine, right? You got to do business with Caris now for that. So that's the point where I'm not sure that we've have a very good public policy framework discussion about that.
Right. And I will just add, one thing that is interesting about what you're bringing up, Jose, is, and this is related to one of the things that Danielle was talking about, was, some of the things that are disclosed and the risks that are disclosed are focused more on the particular harms to the participants. And that might not encapsulate everything that is concerning to the potential participant, right? So the monetization of your data, the fact that the data is going to be held in this private company rather than, be available to any researcher engaged in sort of biomedical research, like those things. When we do the surveys, like people really make those distinctions about whether or not they actually want to participate in research, but it's hard to, it's so complicated to even think about from a researcher perspective, how can we even present this kind of information to potential participants in a way that is digestible? I don't know if you have any sort of follow-ups on that, Danielle.
Just that it's a really interesting problem that I haven't really thought about, and I think you captured one really important part there, Dana. I'm also thinking that because this is sort of integrated care and research, and also possibly not even research, as you were talking about the sort of quality improvement distinction, and it sounds like from what you were saying, Jose, that there's not really a way that patients can opt out, because this is just happening. Nurses taking their data, that's required for figuring out what's going with them. And it's just, then it also gets used for this secondary purpose. So, the horse is already bolted. How do we figure out now, sort of after the fact, what that person's actually consented to there? All I can say is that it's a really, really interesting issue. And fascinated by all of the aspects, including that integration of care and research there.
So I have some questions, and thank you, Michelle, for asking a question. We're going to bring this up live, but if you, audience, have any questions, please start typing them up in the Q&A, and I'm just gonna ask one question and then I'll start going to audience questions. One of the things that José brought up that we haven't talked about, and I'm very interested in sort of hearing from everyone's perspective, is this sort of differential risks and the potential sort of vulnerabilities that different people might have. In my conversations with José, I know that this has been an issue. I mean, both José and José work with participants who could be categorized as vulnerable, or at least subject to a lot of pressure related to research participation. Either they're very sick, or they have developmental or intellectual disability that makes certain forms of communication more tricky. So if a patient or potential participant is interested and willing to be part of the study, but you worry that they don't fully understand what the study entails, how should you proceed? Can you think of situations where it would be appropriate to let someone participate in the study, even if they were, because they were fully willing to participate, even if they weren't fully understanding of all the sort of details of the study entailment? And this could be to anyone who wants to sort of chime in. If I don't get any takers, I might point to somebody.
I mean, I can comment about some of the settings where my patients. So I don't see the patients directly. I diagnose things, but I'm in my role as the neuropath director. One of my roles is ensuring that we have the testing for our patients, so that the oncologists who look at those patients in the eye, tell them they have cancer, and give them a plan so that they have the information to make that best plan. So one of the issues that comes up is the health insurance policy framework that exists in the United States oftentimes does not cover certain types of testing that, even if that testing is present in a clinical practice guideline, okay, it is often not reimbursable. And at a place like Ohio State, where we're already kind of majority government paid insurance with, I think we're like 55, 60% public aid Medicare, this is like a big issue for them. Okay, so if something, even if it's $600, that's not covered by those programs, that's a massive burden to the patients, right? So, so the context here that existed for me, and so this wasn't research, this was just practice, this was just care, healthcare, right? Every day, day to day. I saw a situation where patients were getting consented to do this molecular testing to a company that did full-blown data monetization. That was their flat-out business plan. We're not going to charge you, but we will charge a subscription fee to access your data to biopharma. That's how they're providing the care, the testing. And I had like something in my value system and in my gut. And at this age, I've got more neurons in my enteric nervous system than my central nervous system. So I just went to, actually, I went to Dana and said, well, what do you think about this? About a year ago, I don't know when that was. And so for me, when I felt that there was a little Spider-Man sense of something a little bit that I wasn't fully comfortable with, but I couldn't even understand why, because I'm not a philosopher. I don't have any training in this, but there was something that didn't sit well with me. And so I reached out, and I was lucky that we had a bioethicist in the college to discuss, and we explored stuff. And I identified a company later, which their business model is distinct, in which they've centralized so much their workflow that their cost per patient is so down. So even if they get horrendous reimbursements from government insurance, they can still break even on those patients. And they're really making their reimbursement and their business model through private insurance. And they taken all like the Medicare, public aid, and so forth. So that was an example of how I saw a situation I was really uncomfortable with, but I didn't know why. We identified the issues that were disturbing, and I changed my workflows.
Go ahead, José.
There's so many ways that I could approach that question. I think in a practical sense, you know, having thought about this, having studied this, that I want to say to other researchers, if you find yourself asking this question, you have that discomfort in your gut, you cannot be in a rush. And this seems like so basic. This is not science, right? Don't be in a rush, take your time, but it's like really important. The consent process is seen as purely procedural. It's something, it's a box to check off. It's a document to cover me legally and tuck away in a file that won't be opened again. It's in case of IRB audit. And it cannot be that if you want to aspire to purely informed, you know, truly informed consent, to really taking this seriously. And I'm reluctant to say, I'm not saying it's not possible, but reluctant to say that there's a point where I would decline to allow someone to enter a study because of concern about their comprehension, say, of the materials. But if you're unsure, you don't proceed, you educate. You say things in a new way. You make these modifications. You have to have a plan. You can't assume that researchers are going to be able to do this on the fly, right? You have to have a plan of what if you're concerned that someone doesn't understand, and how are you even going to have that on your radar if you don't have a way to assess comprehension, which is completely ignored, right, in the standard informed consent process. And I think this doesn't come up if you're not doing research with special populations where there might be some concern about their comprehension at baseline. But as soon as you're asking these questions, you're entering into this ethical tension of, we don't want to enroll people in studies they don't understand. We don't want people to sign their name accepting risks that they don't appreciate how they might affect them. But the other side of that is that there are benefits to research, and there's reasons that people do want to enter research. And if you don't have representative research samples that are representative of the population, then you can't generalize your findings to the population. And if people like you are not in research, then people like you can't benefit from research. So you have to be careful not to become too paternalistic, too protective of this sacred space that, you know, you need to pass our bars. And that's why proxy consent and these procedures are in place. But that also is not a blank check to then not care. That's another thing that is really commonplace, that if, you know, we care about the legally designated decision maker, their comprehension, and the assent is now reduced to something purely procedural and rushed along. And I think that that's incorrect and unethical. But sometimes you're doing research and that person who cannot make the consent on their own, maybe they can't speak or can't read, or, you know, that those people need to benefit from research too. And sometimes we talk about this sliding flexible scale of risk and the whole situation. What you're looking for is clear dissent. Any clear indication of, this is not where I want to be, this is not what I want to be doing. And you have to walk into that room ready to respect that and ready to say, well, you know, my valuable afternoon didn't pan out because, I found this participant, I spent 2 hours talking to their family and they wanted to leave. So I said, we can't, right? There was clear dissent. And you have to be ready to put those principles before your own bottom line or, your data.
I just wanted to add one thing. I completely agree, actually, with everything you said, José. And I wanted to just add that I think this does point to different functions of the informed consent process. So I think that one thing, personally, I think is important is knowing how minimal the understanding might be for a rights waiver is important, like knowing that you're not going to violate someone's rights. But when the research is high risk or the risk-benefit ratio is unfavorable, then you might want to re-educate, retest, and that might look very paternalistic for someone who has a position like mine, but it's not actually, because people don't have a right to be in the research. So you might say, look, yes, research is a wonderful opportunity sometimes, but I'm going to make sure that I add some extra kind of levels of security, understanding, so that people can make good decision making before I allow someone in. But I would also emphasize that that, you know, when we have problems with understanding, especially in patient populations that don't presumably have flags for cognitive disabilities or intellectual disabilities, this is another warning sign that our disclosure process is probably problematic.
And there's a lot of questions from, I'm trying to show the audience also what questions there are, and we'll try and pull some of these questions and put them on the website when we also post the recording. But one important sort of distinction that I think is useful to make, Danielle, is the difference between understandability and understanding, right? So can you just let us know a little bit how you're thinking about those two sort of concepts?
Right. So to ensure that you're not exercising control over someone's decision, you want to disclose information so that they can factor it into their decision-making process if they so choose. And one of the features about respect for competent adults is that if you really respect autonomy, you have to respect that sometimes people are going to make poor decisions, sometimes they're going to make foolish decisions, sometimes they're going to make risky decisions. But as so long as they're able to make those decisions and factor that information in, that's really important. So that's what we mean by understandability. That's what we mean about a disclosure process that facilitates understanding. Now there's a separate question of, do you have to understand that information in order to waive your rights? And that's where Joe and I come in and say, well, actually, in order to waive your rights, in order to release you, if you're my researcher, from a duty not to trespass on my body, say, what do I actually have to understand? And there we think, well, you have to understand what you're permitting the researcher to do, where that might involve bodily trespass through, say, a blood draw. But we want to preserve that. If we really want to respect autonomy, we want to preserve the idea that people should be able to make decisions in accordance with who they are. And sometimes, if you're a warrior like me, that will involve doing all the research and making your pro-con lists, and other people might be making more impulsive decisions. But have they had access to the information that would be relevant? And this is sort of where we get Jesse's really important work about understanding how people process information and making sure that we're attending to that in our consent processes so that people really are able to make decisions and have access to information that might be relevant. Does that help?
Yeah. And so here's a question that comes up a lot, I think, for clinicians and for IRBs and the research community, is this worry about therapeutic misconception. So it's like people think that what they're doing is, when they're participating in research, is they're getting cutting edge, innovative treatment. And they don't necessarily understand the fact that what they're consenting to is to participate in research rather than clinical care. Is that something that we should not worry about as much, or is this something that is like part of what should be understood in the understanding in order to give valid consent? And this could be for Danielle, but for others as well.
I guess I think that the therapeutic misconception is really about disclosure again. I mean, I think that it's really about recognizing the ways in which certain disclosure processes, the context in which we conduct this, can facilitate those misconceptions rather than oust them. And so it's really important, I think, to make it clear what this is not. And so, you know, one of the problems with the consent form and the way maybe we go through it is we maybe don't emphasize the most important information first. What is it that we really want people to get? And if we have a patient population where we're very concerned about therapeutic misconception, then we start there and try to disabuse somebody of any misconception first. I guess I don't think it's necessary to understand that, but I do think it's important that you've given somebody that opportunity. And that involves a disclosure process, again, that it is focused on facilitating that understanding, where that might mean reordering what you end up emphasizing or disclosing because you're particularly concerned that this is a misconception in this particular population.
If I could just add to that point, one of the things that potentially as a mechanism as to why people believe that things are this is somehow better or more cutting edge, is that you can't take out of the equation that this is a doctor-patient relationship, and there's a cultural history of benevolence in that relationship. And so the patients are coming in anchored from that mindset where they wouldn't, in general, they wouldn't believe that this would be suggested if it wasn't in their benefit. And whereas the clinical research team is looking at benevolence from the population standpoint, not at the individual standpoint. That's just a comment I want to make.
We probably have one question, time for one question left, but like, thank you. There's so many important questions that I think are going to give us feedback for having new and more panels in the future. This one comes from Joanne Penderson, and I think it's a nice way to sort of close the conversation. So we still haven't fully addressed the issue about researchers understanding the language of the consent form, especially template language. There isn't sort of enough training. So what is the ethical responsibility of the institution to the researcher? And what does the ethical responsibility require the institution to do with respect to training, education, and compliance moving forward?
I have more like comments that potentially border on venting on this question. Okay. I've seen some of these documents, quite frankly, and I don't know, Jesse's probably seen more of them, but to me, they sort of seem very schizophrenic. Half of it looks like something you take out of Staples or Office Max, like from a shelf, that is crazy stuff that doesn't seem to be relevant. And then other half is like, boom, like really complicated. And I have trouble understanding it. From the researcher side, there's also a pressure, an organizational pressure. You have to do research or else you lose your job. I mean, that's a real pressure. There's a financial compensation issue with it, in the sense that, you know, your job to do research. If you do research well, and you may get promoted, which would likely result in a compensation change for you. There's an ad nauseum list of, and at Ohio State, we call them computer-based learning, or CBLs, that just keep on getting bigger. And they're very ineffective, actually, in achieving the learning objectives of what they're doing. Although there's like a quiz at the end and you pass the quiz. But quite frankly, the only time where one of these CBLs changed a behavior of mine was when we were like back in college, when I'd never heard of these things, and I was taking one on like radiation safety. So that helped me in that. But most of the time, these things are very poorly done. They're transactional on the researcher side, and it's so onerous that it, even for something as serious as this, it's like, oh gosh, not another one. And so I think that there does need to really be an improvement in this for the researchers. So.
Yeah, I think one thing that I thought of when you were saying that, Jose, is that, you know, you never see in a disclosure of conflict of interests, like the inherent conflict of interest in the research, that, you know, my job's on the line, or, you know, this is something, I have an interest in the success of this study. And you know, people point out problems with issues related to positive publication bias that are related to that, but not in the consent process. And what I was talking about before, you have to be willing to walk away. If you're going to do this ethically and correctly, you have to be willing to say, you know, this person was informed in saying no. You can't just present the bright side, you know, the upside of everything. I forgot. Oh, something else I saw in the comments. Another question was about physicians being required to be present, presumably for randomized clinical trials for biomedical research for consent, and that it's an IRB requirement. And what I thought of as my answer to that before this question was posed, that I think my concern with that, having been on that kind of a trial and being the non-expert researcher who needed to stand behind the psychiatrist, right, is that the physicians, with no offense to anyone, may or may not understand the research protocol with the depth that's actually needed to have those serious discussions. Anyone can read the consent form out loud, or almost anyone, depending on how multisyllabic and how heavy the jargon really is. But to be able to engage in discourse and talk about the hypotheticals and talk about all the possible things that happen, I would never say, therefore, the physician should not be present, because was I equipped to talk about the biochemistry or the possible side effects? No, that wouldn't be appropriate. But someone who has true mastery of the protocol must be present. And often physicians are busy and they're co-investigators on 10 important trials, and they have different interests. And it's not knowing the 20-week protocol inside and out. So I think it's a good and important question. And we should consider whether we're assessing comprehension of the consent materials in the participants, but it probably, in addition to your city training certificate, should be a requirement before you're consenting others to a research protocol that you meet a very high bar of mastery of that research protocol. And that I am comfortable with saying there should be a firm line of, you need 100% on that quiz.
Completely agree. And I guess the other thing I would add is that as we know, Dana, as philosophers and teachers, you can have people who have mastery of the material who just cannot communicate it in any other way than that very high level. And I was at NIH during a disclosure process of a delightful researcher who was so excited about his research, and he was so excited about all of the things he was going to tell these research participants, and we had to sort of explain they're not actually that excited about how cool their cells are. They're quite excited about this particular risk for the family. And it's sort of trying to, yes, having that mastery, but then also, are you able to translate that knowledge to people who, this isn't their life work, this isn't an area that they understand, but it's going to be really important to the decisions they make.
Well, thank you so much for all three of you. We're already over time, but this is going to be the first of many conversations about some of the issues that were brought up by you as panelists and by the audience related to informed consent. And one of the things I'm hoping related to just sort of the trainings and education is actually having these kinds of conversations rather than just sort of the automated CD trainings. Do sort of facilitate conversations with you and facilitate these conversations with your team, right? So these are conversations that we could have like institutionally, but also you could have within your research teams about what it is that you really want to get out of the informed consent process. So thank you again, all that were joining, and thank you for the panelists. We are actually going to have another panel next week on the power relationship between researcher and research participants. So hopefully I will see you all there. Go to the CHV website to get information about that. And thanks again, Danielle, for joining OSU for this conversation.
Thank you.
Bye, everybody.
Thank you. Bye.